Hi, and welcome to this video snippet on pathoanatomical diagnosis. Basically, what this is you naming a structure and the pathology that's affecting it. This is basically what medicine does. And for some reason or another, PTs in North America seem to be embarrassed by it. It's not the sole domain of physicians, and there is absolutely no reason why we shouldn't be using it, and every reason why we should. If we're going to communicate properly with doctors, we've got to talk the same language, and this is a perfectly acceptable language. So we're going to be looking at why this is better than using clinical CPGs, clinical practice guidelines, and also treatment-based classification screens. So let's get to it. So what makes this diagnosis? Well, here's some examples. Sometimes the diagnosis is complete, often it's incomplete, and sometimes it's just not a diagnosis at all. First off, you'll see a few things there with syndrome in the name. Syndrome essentially means a cluster of signs and symptoms that are characteristic of a condition that we don't know is causing it. So there's not many of these left. These are all hangovers from previous times when they weren't sure what was going on. But most of these now can be done away with, and they should not be counted as diagnoses any longer. Anyway, we look at these from top to bottom. Spondylogenic headache is the diagnosis. This means basically the pain is coming from the spine, the spinal muscles, the ligaments, joints, and so on. Partial diagnosis, which is less specific, is cervicogenic headache. Means it's coming from the neck. Now, this could be the same as spondylogenic, except in the neck you've got other structures as well, notably the vertebra basilar or the vertebral arteries. So it's much less specific than spondylogenic headache. And then as a non-diagnosis headache, this is simply what you moan about, and they say, I've got a headache, and you say, that's the diagnosis, it's a headache. We'll look at another example, lumbar segmental biomechanical dysfunction, which is about as precise as you can be if you before you do a segmental biomechanical exam. Partial diagnosis will be a mechanical back pain, but again, this is less precise. This includes pretty much everything except for things like tumors, MS, the disease processes that are not really caused by mechanical problems, so much less precise. And a non-diagnosed in this case is low back pain. I remember when I was a student, one of the first jobs I had was working at the gym, and I had a patient come in with a diagnosis of back pain from the emergency room. And I said, I'm putting up with that stuff. So I sent the patient back to the emergency room with a request for a proper diagnosis, and it came back as low back pain. So these are not diagnoses. Again, it's a matter of saying to the patient, where do you hurt? They say, in my back. Whereabouts in the back? Low down. Oh, you've got low back pain. You're simply regurgitating the patient's symptoms. Let's not do that. Another example is entrapment of the sciatic nerve, so it's a sciatic neuropathy, and it's from piriformis adhesions, basically. These types of things do occur, but they seem to be post-trauma, so you get scarring and fibrosis, and the nerve gets caught up in it. So that's a very precise diagnosis. Less precise is entrapment of sciatic neuropathy, and no diagnosis with piriformis syndrome. Disconnection with radiculopathy is pretty complete. Radiculopathy isn't. It's not telling you what's causing the radiculopathy. It could be a disconnection, it could be a neuroma, it could be stenosis, lateral stenosis. There's a number of things this could be. And a non-diagnosis now is sciatic, because that simply means leg pain coming from the back. So pretty much you're not getting any information from there. Grade 2 biceps tear could be made more precise. This could be traumatic. It could be degenerative, so you could make it a bit more precise, but for most of our purposes, grade 2 biceps tear is pretty good. Biceps tear is again less precise because it's not giving you the grade. Muscle strain is a rubbish diagnosis. Which muscle and what the hell pathology is a strain? Now, you understand it to mean a tear. You're not a lay person. Let's call it what it is. It's a tear. This is like, it's a muscle irritation. What the hell is an irritation? Supraspinatus Tendonosis, as opposed to rotator cuff tendinopathy. Not all of the rotator cuff are affected. One of them is, and you're not getting anything from this. Also, the term tendinopathy just means tendon pathology. You have no idea if it's a tendonitis or a tendinosis. Impingement syndrome sucks, outright sucks. What's being impinged? Is it the subacromial bursa? Is it one of the tendons? What is this? Also, if this had been called pinch syndrome, you would never use this. It would never survive. Median neuropathy from pregnancy fluid retention or sublux lunate, or even diabetes, is very precise. Median neuropathy, it gives you the anatomy, but it actually doesn't give you the cause of it. And carpal tunnel syndrome is another one of these hangovers that really should be there. It's not a syndrome. We know exactly what median neuropathy is. So let's have a look at having a look at a different type of diagnostic that isn't pathoanatomical. Now, this is actually a combination of treatment-based classification and a clinical CPG. So if you look at the top there, you'll see what something should be fairly familiar to you. This came out quite a few years ago now, and this is the prognostic rule, if you like, for manipulation. This wasn't intended to actually develop this way as a diagnostic tool. It was just there to say, if you're going to do a manipulation, if you have all of these signs going with it, you're going to get a good result. If you only have one or two, the result is probably not going to be really good. So it's a prognosticator. So no symptoms distal to the knee, symptom duration less than 16 days, fear avoidance belief questionnaire less than 19, lumbar hypomobility, hip internal rotation 35. Now, when this wasn't being used as a diagnostic tool for a very short while after it came out, it's not too bad. I mean, I've got issues with this. Who the hell is in an ordinary private practice is going to look at somebody spending time filling out a fear avoidance belief questionnaire, for God's sake? If you don't know that this person is scared stiff, then you're not doing your job. Of course, there's a lumbar hypomobility. That's why you're manipulating it. I've treated patients way over 16 days and done well with them. Hip internal rotation, if it's not 35 degrees, figure out why it's not. And you can often fix this just by manipulating the hip, and that one's gone. So even when it was just used as a prognostication tool, it was not great because it also didn't offer any alternatives. So I can't manipulate because manipulation is likely not going to work. What's my next best treatment? When manipulation is called for, even if the chance of it not working is present, what do I do next? And you never got that information. Now it's being used as a diagnostic tool. And this is where it sits on here. So if it doesn't fit into the manipulation thing, this is the way this CPG goes. Extension exercises. The symptoms are distal to the buttock. The directional preference for extension is present. That is, they prefer to be extended rather than flexing. Or if you prefer it, flexion bothers them, is more impaired than is extension. Symptoms peripheralize with flexion and centralize with extension. Oh, great. Okay, fine. Now, where is the alternative? We look at flexion, and now we're getting specific to the patient. Prior to this, it's just what the symptoms do it. Now we're getting specific to the patient. Age, 50 years and more. Directional preference for flexion, evidence of spinal stenosis on imaging. So we've gone from a non-pathoanatomical diagnosis classification to one that requires a pathoanatomical diagnosis, spinal stenosis. So there's something entirely wrong there as well. There's also an assumption here that anybody over 50 years old who has a back pain that prefers to flex rather than extend has to be stenotic, and that's not true at all. So you would be better off doing what Mackenzie did. That is, bend them forward a few times, see if they get better. If they do, fine, that's your exercise program. Bend them backwards a few times, do they get better? Yeah, that's your program. So this is much better than this stuff. It's much more direct, it's experiential, and you'll get a result with it one way or another. Your only problem then comes is if the exercise, the flexion, don't help at all. Now, there's nothing on here to help you with that. Lateral shift, that's not difficult at all. You see it, you correct it. If they fall over screaming, then you can't correct it. It's probably a disc. If it does correct, then you correct it. This is not difficult. Stabilization. Age 40 odd years, straight leg raise more than 90 degrees, aberrant motions in the prone instability test. Okay, now, just because they have an instability present, it doesn't mean to say that the instability is significant to that patient coming in to see you. You can pretty much guarantee that anybody over 40 years is going to have a segmental instability present. So do you do stabilization on everybody, even if the aberrant motion and prone instability test is negative? And again, if it's not there, now what do we do with them? So we can only exercise people who need stabilization therapy. Where's the rest of these people? Traction, presence of leg symptoms, signs of radiculopathy, and peripheralization with extension and cross straight leg raise. That's a disc. There's no doubt about it, that's a disc. So why don't we call it a disc herniation? And then they're suggesting a traction treatment, which hasn't been demonstrated to be very effective with disc herniations anyway. And that's your treatment for it. If this hasn't been diagnosed, it needs to be diagnosed properly, proper imaging, so that the disc herniation could be staged. If this is a nuclear prolapse and it's hitting the nerve root can degenerate very rapidly, and that can be permanent damage. And it's not about compression, it's about contact now. The nucleus is a neurotoxin. So don't mess with this. I mean, traction probably won't work with a proper disc herniation anyway. It's certainly not going to work if you have a radiculopathy. Get it seen to properly. Get it imaged, get it staged. So these these CPGs and exercise treatment classification schemes are all very iffy. What you're doing is you're relying on an expert, supposedly, and his opinion. There's not that much at scientific, even when they do these systemic reviews and meta-analyses, though the individual studies don't usually bother with manual therapy. They don't usually bother with a manual therapist, an expert manual therapist. And it's all about exercise, stretching, stress, and all the rest of this stuff. What they should be doing is comparing somebody using CPGs or classification systems with an expert in that field, a manual therapist or an orthopedic therapist, if you like. But an expert therapist is going to do whatever the hell they're going to do, and a therapist is only going to use CPGs or treatment classification. Then see what happens in it. If they really want to do science, that's exactly what they would do. I have never seen that even proposed except by manual therapists. So that's it. Pathoanatomical diagnosis. You make a pathoanatomical diagnosis, you can treatment plan from this very easily. You've got inflammation, you're going to use rest, ice compression, elevation. And as I said to somebody answering a question, rest isn't the avoidance of all stress, it's the avoidance of adverse stress. So exercises are perfectly permissible with an inflamed patient or inflamed tissue, providing those exercises don't make it more inflamed. But you've got a treatment plan for an inflammatory condition. If it's a segmental dysfunction of the right type, you've got a treatment plan. We're going to manipulate it. We're going to assume it's an instability anyway, because it did manage to sublux and jam up. So we'll do stabilization and movement rehab. This stuff is not difficult from the treatment plan. It also allows you to progress your treatments properly. And also, if your treatments are not working, to figure out a different treatment, which these CPGs and treatment classification schemes just don't do. So I can't recommend this enough. You're in the right program for pathoanatomical diagnosis. I would use this over any other form at all. Okay, so I hope that's useful to you, and I will talk to you again soon. Take care, everybody. Bye-bye.